Thank you very much. Good morning. So now we are talking about the plate fixation for the femoral fracture at the shaft. So as we know that the plating of the femur, when we're using the conventional techniques, which always open like this previously, and the bone is exposed all over the femur, using the plates like this, and the soft tissue is retracted to the side. So the result is we often find that the failure of the fixation and high rate of infection and non-union. But all of these things related with the soft tissue is not well respected in this condition. So at that time, the antegrade remote intramedullary nailing of the isolated closed femoral fracture has become the gold standard of the treatment. With the higher rate of the union, lower rate of the infection, and provide the early weight bearing. But the intramedullary nailing is not the answer for all of the fracture at the femur. We can see here the problem is the complication of the fixation by using the nailing. The pulmonary effects, hip pain, and abductor weakness, osteonecrosis, femoral neck fracture, pudendal nerve palsy, and there are some technical limits at the distal and proximal part of the shaft of the femur fracture. And there is a knee pain and the risk of knee sepsis in the retrograde nailing. And there is also symptomatic distal locking screw. And the other one is the malunion, that especially the rotation that can occur about 15%. So why we need to plate the femoral shaft? Why we choose this? So there are some issues that the system issues. If there is a lack of fluoroscopy, as we know that many parts of the world is not easy to find the II, to have a close nailing, and this is the inexpensive solution for this kind of fracture. And the patient issues, the pulmonary status of the patient, and the patient with multiple injury, polytrauma patient with bilateral femoral shaft fracture, and also the fracture issues in the small medullary canal, and the proximal and distal fractures usually better managed with plates. In the patient with bilateral femoral fracture, in the multi-trauma patient, the stable patient, usually we can help with applying the plate, because the plates can be quickly done, and there is a minimal blood loss, especially if using the MIPO technique, and the setups become easier, and the fixation can be done simultaneously. And this is the latest progression about the plating, minimal invasive plating. It allows the preservation of the periosteal and medullary blood supply. So we can understand that why is this procedure has become better and better, especially if you use the special plate like this. And it's possible to use the bridging techniques and have a relative stability, and there is no disruption of the fracture callus. And it has been shown that this improves the union rates, time of union to union, decrease the complication rate, and also avoid the complication of nailing. And there are some specific indications for plating. When there is a vascular injury, ipsilateral neck and shaft fracture, proximal and distal extension of the femoral shaft fracture, if there is a pre-existing deformity, and if there is a non-union periprosthetic fracture, and also this the pediatric fracture. Yeah, we can see here at the X-ray, there are some indication for the plating. So this is a sample of the pre-existing deformity, the patient with Paget disease, and have a femoral shaft fracture. It's a bent shaft of femur, and can be fixed by using the plates. And if there is a narrow or absence of the medullary canal, so sometimes we cannot access the medullary canal, so it's become difficult to nail. And there is a previous hardware. You can see here that the previous hardware blocking the medullary canal, so we cannot use the medullary canal for the fixation. We can use the plate for the fixation. And if the medullary canal is too small, yeah, like this kind of deformity, we can also use the plate for the fixation. So for the periprosthetic femoral fracture, the case says that if we evaluate the patient and the prosthesis, if the prosthesis is stable and patient able, we can do open reduction and internal fixation by doing plates. And if the prosthesis is already loose, we can change the prosthesis with the long stem one. So this is the pediatric patient. Yeah, for the pediatric patient, we're concerned about the open growth plate that we don't want to disturb, yeah, at the distal part and also at the proximal part. So we can use plates without any disturbing of the growth plates. So antegrade nailing, we can have a problem of the AVN and the trochanteric growth arrest. And from the retrograde nailing from the knee, we can see that the growth plate is very active here. If we disturb the growth plate, it's become a problem then. If there is a non-union or malunion due to the instability, so the plate can be used for the more stable and better prognosis. So the plate is very versatile implant. Yeah? So we can use more flexible for the indication and also the situation of the patient. And we know that the plating and also nailing both can have a good clinical result as long as we concern about the personality of the fracture, the condition, the indication, yeah, so you can have a good result of the clinical. And plating have an advantages in many situations. For pediatric patient, for the ipsilateral shaft and neck fracture, periprosthetic fracture, non-unions, and some deformities of the femur. Okay, thank you very much.